Hello everyone. Welcome back to the Doc Suit podcast, where two resident physicians, Mohit and me, are exploring how healthcare has moved beyond scrubs and white coats. Today we have with us Dr. Elizabeth Ghandakly. She's a resident physician in internal medicine at Cleveland Clinic and an aspiring cardiologist. Born in Ohio, Dr. Elizabeth started her career in law. She pursued her pre-law and law at Ohio State University. And after graduating, she's worked with clients like IBM and Oracle as their senior corporate counsel for a few years. However, during those years, she continued to gravitate towards healthcare. She took up the opportunity to serve as part of the Alexandria Public Health Advisory Commission and later on went on to work as a patient care volunteer in Children's National. Realizing that her true calling lay in medicine, she took a leap of faith and transitioned to a career in healthcare. She went on to pursue her medical school training from the George Washington University School of Medicine and is currently a resident physician in internal medicine at the Cleveland Clinic. Happens to be my senior. Apart from pursuing her residency, she continues to devote time towards advocacy and education, with her pieces exploring themes like public health, health policy, patient advocacy, bioethics, medicine in conflict, immigrant rights, and so many more. Welcome, Dr. Elizabeth. Before we begin, I'd really like to know what keeps you going. You have transitioned from an incredibly academically punishing path to another one, and we'd love to know what's your secret.
Thank you. It's really great to join you guys. I appreciate your having me on. It's nice to talk with you about all these important issues and things. I think for me, I'm just a very curious person, and so I'm just interested in learning a lot of things. And sometimes I joke with my friends and family, and I say, I just kind of want to be able to experience everything. I think that's part of what drives it for me is, I have a lot of interest in things. I like kind of getting to the bottom of what's driving things, and I think that got me interested in both law and medicine and ethics and kind of everything in between. So I think it's helpful to just be curious, I guess.
Being curious and kind of pursuing that curiosity to the point that you actually get to the bottom of it. That's the secret sauce, it seems.
I think so, yeah. And if you can combine that with, trying to help people in some way, that's also, a good driver, because then you can see some benefit to it.
So I think to kick things off, I think the first thing a lot of people would like to know is, how has your background in law shaped your approach to medicine and your patients?
It's interesting. I think on the surface, a lot of times people think law and medicine are very different fields, right? And they are to a degree. I mean, the subject of them can be very different, but there are a lot of intersections between the two, right? I think one, if you're looking at kind of a field where you work in a field as sort of a person who is helping others and sort of working to, advocate for others or do something for others, I think both of those fields do that. And in similar ways, right? I think in law, when you have clients and you're kind of practicing law, you really are working to see, okay, what does this client want to accomplish, and what are their, risk profiles, right? What are the things that they are okay taking risks with, and what are the things that they really don't want to take risks with, and what are the benefits that they really need to get, right? What are their kind of, priorities, basically. And so then you as a lawyer are kind of responsible for saying, okay, here's what the law says, here's what's likely to happen, and here are your options. And I think that really does play into medicine also, right? Because I think when you're a doctor, you end up, doing sort of the same thing on a different level, right? You have a lot of patients who are coming to you. They may not know, at this point, it's not about not knowing the law or not knowing legislation or regulations, but they don't know exactly what medications are available to them or what treatments are available to them or what's driving their pathology, right? And so then you are responsible really for explaining it to them and saying, okay, here are some options for you. What is it you want to accomplish? What are you comfortable with? And, what do you want to do? So I think that there's a lot of overlap in that way, kind of in the communication sense, right? So you're really working with someone to say, here's what I know, and here's how I can help you kind of accomplish what you need to get. So I think that's one way, which has been helpful kind of to tie the two together.
That's actually very insightful, Dr. Liz. But you had mentioned about advocacy, right? So the term varies itself from person to person. And I've spoken to several people, they have different definitions for it. So what does it mean to you, and how has it influenced your journey in medicine? Because you have a background in law as well.
Yeah, I think that's the other piece of it for me too, right? Is, I think what I just talked about was sort of the individual clinical approach, right? You're kind of helping somebody make decisions and understand the lay of the land for something, be it law or medicine. But on a bigger level, I think the thing that really is an umbrella to all of these fields is that idea of policy, right? I think if you're in either field or whatever field, you're going to be doing your day-to-day work where you're working with an individual and saying, here's what you can do, here's how I can help you. But I think it's, for me anyway, a driver to always think about, what are the bigger aspects of this and how can you help people on a broader level, right? And that's sort of public health, right? So I think, in law, people kind of go into law who maybe have a mind toward advocacy sometimes because they're already interested in sort of some of these things like policy. In medicine, sometimes it doesn't occur to people until they're already in the field. I think I know a lot of people who, get frustrated in medicine. They say, oh my gosh, insurance isn't covering this for my patient, or I have to, try this medication before they'll approve a different medication, or, the system is really not working for my patients who, can't, transport themselves to the hospital and all these things, right? You get frustrated by these things, but I think the next step is then to say, okay, how can I help this situation on a policy level? And I think sometimes my colleagues in medicine don't necessarily take that step because often we'll think, well, that's kind of not my lane, right? I'm not a legislator, I'm not a lawyer. I'm just trying to kind of help my patients out. But I think that that's the key, right? I think that if you are willing to sort of look at that and say, well, I have a lot to offer as someone who treats patients and as someone who knows what these problems are. And then you can say, okay, how can I get involved in this space? And then that can bring you kind of to the next step of advocacy, which is, helping your future patients and helping kind of all patients really.
So I think what you're saying is like by being a physician, you're kind of getting a real world experience. You're really understanding all of the problems that people are facing, but then with your experience in law, you're not only able to address those problems on a bigger scheme as well, but then you're also able to fight for things that that patients are facing. You're able to fight for them because you understand the mechanisms that go behind the scene.
Yeah, it's a good way of putting it. And I think what I'm also hoping people, whenever I talk to people about this issue can kind of see is that we can all do that, right? Even if we all didn't go to law school or we all didn't study this. And I think I've seen that when I've done policy work, right? So when I worked as a health policy advisor for a state legislature, for example, I would see how these things kind of get written and how legislation gets introduced in the state legislature and, who talks about these things, kind of the different groups that will weigh in on whether it's a good legislation, a bad legislation. And, I was involved in that, which was great. But all along the process, there are very few people really active in medicine who are involved in these passage of legislation, right? So you have these things that are going to affect, how hospitals run, how insurance companies, work, how Medicare reimbursements happen, these kind of things. And all along the way, so many of these people that are passing these laws are not talking to doctors who can be, an advocate, not only for what we see in the hospitals and then the clinic and how these things actually work, but also an advocate for the patients that we talk to, right? So I think that the driver there for people, even if they don't feel like they have a great understanding of kind of law and policy, is they do have a great understanding of, their experience with patients and what needs to change. And so I think that that's helpful.
So you've noticed a significant gap in terms of actually patient advocacy when it comes to a policy level, when it comes to a technological level, when it also comes to a clinical level, if I'm not mistaken. So what is the issue exactly? Why aren't they talking to doctors? Why aren't public policymakers talking to doctors? Why aren't technology startups talking to doctors? Why aren't administrative staff talking to doctors?
Yeah, it's a big question, and I've tried to address it, in ways that I can, right? And I think that, at least from my perspective, there are a couple of parts to it, right? I think one is, what drives policymakers, right? It's going to be getting reelected. It's going to be, to some extent, donations that will help them get reelected, people who view what they're doing as good for the community, as good for their constituents, right? And so, I don't think that everyone is necessarily coming from a bad space when they're trying to pass legislation, but I'm not sure that the incentives are always there to talk to people who are going to really get the best legislation made, right? And I think they're open to it, right? And I think the times that I've gone to Capitol Hill with different groups and talked with, people who work in, these offices, or the times that I've, given testimony, on different issues and things like that, I think policymakers are very interested in it and they take it to heart and they listen to it, right? And it's helpful. But I don't think that they have necessarily the time or the incentive to seek it out all the time. So that's one piece. But I think the other piece is, if that's not happening, then, there is some need on the part of people in medicine, doctors, to really kind of go out there and say, hey, look, I'm available to talk to you about this. And this is what I know. And these are 5 patients that I worked with last week who are experiencing this issue. I see it all the time. And the policies that you're passing aren't necessarily going to fix it, right? So I think that part is the part that I think is achievable on our end, which is getting more doctors, young doctors, everyone, residents, everyone, med students even, interested for one, and also comfortable with the idea of doing advocacy.
So how do you really integrate advocacy, for instance, into your medical career? And what advice would you give to us rising physicians who are young and want to really explore this pathway itself?
Yeah, what I've tried to do is one, go do things, to the extent that I can, right, with different groups. I think one easy way to get involved is to join different groups within medicine that you share interests with. So for example, here in the US, there are groups like ACP, the American College of Physicians. I know there's the American Medical Student Association that I used to work with in med school. So find whatever groups that seem to align with your interests. And then a lot of times they'll already have kind of a network where you can sort of not do all of the legwork on your own, but you can say, hey, I'm here, I can help, and just sort of use that to get comfortable with it. The other thing that I've done is in the residency program, our residency program is very receptive to this and very interested in helping encourage, people to get involved and advocate, which is great. And so as part of the clinician educator track that I'm in, I created this physicians as advocates curriculum that we've implemented, which is really trying to get to that other piece of it, which is I think that a lot of doctors, rising doctors are not comfortable or don't know how to get involved. And so this kind of lays out the framework of, there are regulations here. What can you do? What can't you do? What is your institution okay with you doing? And then how does the system work, right? Like what level of government is going to pass these laws and kind of pass these regulations? And then how can you effectively communicate with people to kind of make your point? So I think these are the skills that are really helpful for people to have when they do get, motivated or passionate about a specific issue. So I think that's one thing that's helpful to kind of lay the groundwork, at least hopefully.
Yeah, and so you have also worked with many doctors throughout your years, like throughout the journey of your advocacy as well. What gaps do you see in, I wouldn't say doctors, but what lack of aspects or perspectives you see in doctors that they're not able to address these multiple issues? Because, like, for instance, for me, I can see a gap in the process level. So if you're doing a quality improvement project, that's advocacy. If you're doing a policy improvement, that's also advocacy. Also, if you're helping patients make decisions, that's advocacy. But as physicians, what gaps do you see?
Part of the process of this is having done some surveys, asking people, have you been involved with advocacy, or what do you view as advocacy, right? Because I think you're talking about various types of advocacy. It doesn't always have to be going to Capitol Hill, or it doesn't have to be this and that, right? It can be working with your patient and saying, hey, what can I do for you? And how can I help make this easier for my next patients, right, in the system? And so part of it is surveys that have been done that ask people, what are the barriers and kind of what stops you from doing that? And a lot of it is, some of it is real, right? And some of it is perceived. And I think a lot of what people will answer is time, right? Because all of us know that time is so difficult to come by, right? I mean, you'll go to the clinic, you'll go to the hospital, you'll do your day-to-day work, and you're already behind, right? You have to go home, you might have to finish your notes, wake up early the next day, and then somehow find time to do your own things during the day too, to have this wellness. And that's the other thing too, is like, a lot of people will sometimes say, I don't feel like I need to fix the world, right? I'm just trying to be a doctor.
Right.
And so
Right.
there are
Right.
these different perceived barriers and kind of perceived, areas where people will say, okay, this is maybe not enough, like I can't do this. And so then I think that the way to address those is by, one, making it easy, right? So saying, here are printouts of some of the big issues that really are affecting patients that we've looked into, and here's the research. And then just asking, people to say, sit back for a minute and think about the patients that you've seen this past week, and, what stories are there that you think are helpful and moving, right? That you can tell people about, that you can write about, in a way that you're protecting patient identity, or that you can, tell, people about next time you have the opportunity to talk about these things, right? And just finding ways to make it not take up a lot of time is helpful. And I think the other piece of that is doing these kind of like intermittent teachings, right? If you do like a 1 week thing or a 1 day noon conference that says, here's a little thing about how to do this, and here's the thing about how to do this, then you don't have to recreate the wheel. So that's good too. And I think also, there have been some studies too that show that doctors who are involved in advocacy in some way, whether it's, helping their patient, find resources locally for an issue that they have going on, or whether it's, going to certain advocacy groups and talking about a certain thing, they do experience less burnout. And so I think that, spreading the message in a way that, hey, if you try these kind of things, I know you feel like maybe it's digging into time that would otherwise be spent for your own well-being, but it does seem like, at least for a lot of people who do it, it actually is a way of kind of helping that burnout. So.
Okay.
So it's like a win-win situation where you get satisfaction from driving change not only in your patients, but at a policy level or at a bigger scale. But you know that it's not just your patients that are facing these problems. There are probably thousands of people who have the exact same issue. It's just that you're not in touch with them directly.
But yeah, exactly. But I think everyone has something that will affect them that they could hope to change within medicine, right? Either for them or for their patients, right? Be it some of the big issues like, I want to prescribe my patient this medication, but they have to first fail this other medication. And then that takes time. It takes your clinic time. It's time that you could otherwise see other patients, but you have to keep trying this medication that is not the right one for them, right? Or whether it's, you want to get some kind of a reimbursement for seeing, patients who are on Medicare or something, right? So, and like you look at the policies on that, and it's not right, right? So I think that everyone has something that they can tie into that will affect their life in some way.
I think the problem that Mohit and I are kind of trying to address is what we just alluded to, which is physicians aren't talking to people outside of medicine. And we are trying to kind of drive that conversation where, like, even if other people don't want to talk to us, we as physicians want to start having those conversations with people outside of medicine. Like, talk to us, tell us what's going on your end, and let us know and educate us about like what's going on in technology or in AI or in the design world or in law, as we were talking about right now.
Yeah, Sharon is absolutely right. And example, you mentioned medications, right? You have to fail the first drug. And when I was just talking to many physicians throughout my initial days of the residency program, they told me about pre-authorization of medications. And that's the one that prolongs waiting time. That's the one that really denies further medication trials. So even if someone is working on that, that's technically solving a major advocacy issue that is pertaining till date.
100%. And the other thing too, I mean, these issues are so big. And so it's, I'm not naive to say that one person's going to go out there and tomorrow we're going to change the whole system of pay for medical things, right? But, we have seen that there are incremental changes that happen. And, I think the helpful thing is to look at the history of things that have changed, right? If you look at caps on insulin cost, or if you look at, Medicare Part D and how they are, putting into new law that will go into effect later, kind of a cap on out-of-pocket costs, right? So these kind of things are over time helpful, and you can never really point to this person did this and that's why this happened, and it's really a cumulative effect. And so that's why it's hard sometimes for people to see the results of what they're doing, but the more people who are involved, the faster it'll happen, even if it's not fast.
Right. So I think shifting gears a little bit, there's another aspect of this topic that I think both Mohit and I are really curious about, which is the term defensive medicine. It's a term that we get thrown around a lot, and it's a cause of lots of rising healthcare costs, as you know. Can you tell us what that term means to you, and given your background in law?
Yeah, that's an interesting question. I think you're talking about this idea of, people, doctors, people in medicine ordering things kind of to, make sure they don't miss something, or make sure that, if at the end of the day, you're going to have a diagnosis and a treatment, you're going to be able to say, I checked everything, no one's going to be able to essentially sue you and say, you didn't do the right thing. Is that kind of what you mean?
Yeah, exactly.
Pretty much.
What do you guys think about that?
We don't know, so that's why we thought of.
I think the question really is like, why is it that physicians here are so afraid of overdoing things? And like as you know, like when we're even in residency, when we're trying to audit, we want to be mindful about the things that we're ordering for our patients. But then at the same time, I feel like we're always overdoing things. We're always over testing our patients, just because we don't want to miss something. And yes, there is a component where we want to be mindful for our patient, but then there's also this fear of like, oh, what if we miss something and get sued? How relevant is that fear? Like, how real is that fear in your experience?
Yeah, no, it's an important question. I think it comes up a lot in training, as we're all getting better at being doctors and getting better at knowing exactly the right test to order. And it's a much bigger question, I think, right? When you look at, people always talk broadly about tort reform and, should there be caps on, lawsuits and things like that. And there's always so many different sides to the issue, right? So I think if you're looking at it from a policy end, right, and thinking about the legal system and how it interplays with medicine, I mean, you have to kind of think about the extreme stories on either end, right? And I think those are the ones that come into the news sometimes, right? You'll see some hospital or some doctor, right, who didn't order something, and maybe that would have been a really rare cause of something, and then they get sued and lose their license and this kind of thing, right? And then you'll see kind of the other extreme side where some patient goes into a hospital or sees somebody and maybe even sees 4 people and something is missed, right? And so I think the interplay that has happened throughout case law, at least in the US, of all these different, ways of framing, how this system works, I think has left everyone with different viewpoints on it, right? And I think that ties into the part that we learn about in medicine, I think a lot, at least in residency here, which is the concept of, ordering the right thing and the concept of waste, right? And kind of using the system in the best way. Because that's something I think will come up a lot, right? And you'll see it, right? You'll see, you work with one person and you work with a different person, and maybe one person will say, I don't want to miss anything, we're going to order everything, right?
Everything.
And you maybe work with another person who will take a more nuanced approach and say, well, listen, the pretest probability of this person having this is this, the guidelines say that we should do this scoring system. This is the stepwise approach that we should take. We shouldn't order all these labs at the same time. And, that's the right way to do it, right? The right way is to kind of take an approach where you're doing the right thing based on the guidelines, because I think that's what it comes down to in medicine is, we don't always know the right answer to everything, but we know what we know, which is evidence that supports, likelihood of this, likelihood of that. And so that's why, if you want to suspect that somebody has a pulmonary embolism, right, then you're going to do a scoring system. You're going to think about what this and that and order all these things, right? So, all that to say that there's a lot that goes into it. And I think that the way that people in medicine view some of this stuff might be different from the way that people outside of medicine view it, because you maybe don't see exactly what kind of goes into that. What I think is there's almost always going to be kind of a right way to do things, right? And I think that the right way to do things for any individual doctor or anyone in medicine is going to be to have studied and seen so much that you know what to do, right? And that's easy enough to say, but I think that is kind of the right answer, right? Like if you see a patient, then you should know or have enough, energy or enough, curiosity within yourself to think, okay, what is the right way to approach this, right? Should I order 50 labs, or should I order this and then see what it is and do this? And so, I think a lot of times it comes down to kind of just doing the right thing and doing the right approach. But yeah, I don't know if I answered your question, but I think those are some of the points to it. Yeah.
I mean, yeah, but the thing is, every patient is a unique fingerprint. Everyone has the same pulmonary embolism will present in like 50 different impressions. Now, when it comes to really ruling out according to the guidelines, sometimes you can miss things. So that instills fear in doctors. And that's what actually probably gets them to practice defensive medicine. So how do you think, what is your viewpoint? Like we as residents, how do you think we should adapt our training, our learning to actually prevent this overdiagnosis or
overprescription?
Yeah. I think you're right? And I think the only things that I can come up with, and then it ties into something else, which I'll talk about too, but the two things that I can think about to kind of help with that are, one, everyone has a tendency, and you've probably read Thinking Fast and Slow by Daniel Kahneman, right? Everyone has a tendency to have some recall bias and some recency bias, and things that you've seen, you're going to think, oh man, I missed this, or I didn't see this before, never going to miss it again, right? And I'm always going to test for this, right? And so I think having some perspective, within yourself of, what is the reality of this situation right now, and I need to, kind of shield myself in a way from some idea that I don't want to miss something, I don't want to do the wrong thing, and really think and that's what I was kind of trying to get at, which is what is the right thing to do right now for this patient? And what do I really think based on my medical knowledge, that this patient might have, and what do I not want to miss, right? And, if this is something they could have, and I would be really bad if I missed it, I need to test for it, right? I think it also depends on the acuity of the situation, right? So kind of what setting you're in, that kind of thing. But I think the mindset of kind of, trying to avoid sort of the recency bias of things and kind of that is helpful. But I think too, and this is what plays in a little bit to another issue that I think is interesting to think about within medicine, which is, kind of the interplay of, our work with an individual patient and how that plays into our work in the broader kind of public health space. Because I think, most doctors would agree that you have a role in both, right? You certainly have a role to your patient, right? To do the right thing and to treat them and to know what to do for their specific thing they're coming to you. But we also have a role in public health, which is, how is my treatment of this patient or my advice to this patient, or generally, how is that going to play into public health, right? And just, one way to think about that is, vaccines, these kind of things, right? And one person doesn't get the flu shot, is that going to ruin everything? Probably not. Might not be good for that patient. But, in general, we also have a role in kind of protecting the public health of the broader population, right? And so how should our messaging kind of reflect that? So, all of that to say it's messy in terms of how it all plays into, how we can think about defensive medicine and kind of doing the right thing. But I think you just always have to keep it in mind and think, okay, I need to do exactly what's right for this patient in front of me. I can't miss anything for them, but I don't want to cause extreme waste to the medical system by ordering, an unnecessary, $500,000 test that will not get me any further, right? So I think it's always going to be kind of a risk benefit analysis.
So I think the key takeaway here is I have a responsibility to my patient, and that's great. But then, my actions or my involvement in public health is not just something that I do if I want to. It's a responsibility bequeathed onto me as part of the profession. And I think that's going to make me take this entire process much more seriously than I have been, because you do a few things here and there, and you think you do it because you enjoy it, but then when there's a duty involved, or there's a responsibility involved, I think there's an additional level of seriousness that comes with it. So thank you for that.
And second takeaway is follow the guidelines.
And the part about the guidelines is kind of just, it's that old thing about read more, right? Which people always say, it's never the right evaluation of you, but it's always just you're right. I should try to know as much as I can so that I won't miss something and I'll order the right test. Yeah. But I think you're right. I mean, I think it's helpful in a way to put it in that context, because I think, we see patients, and you want to do the right thing for them, but then sort of the arc of treating all these patients is, what are we doing on the whole for people? And then I think that's why it can play into that policy sphere too.
That actually makes a lot of sense, and you've answered a lot of my questions that I've had previously. But one thing I'm really interested in is, like, from a bird's eye view, how can policy really shape access to healthcare innovations? What role do you think physicians should play in ensuring these technologies benefit the broader population, the socioeconomically diverse population as well?
Yeah, I think we're in a really exciting time. I mean, I'm sure everyone says that at whatever time they're in, right? But I think, we have all of these tech innovations, like AI is blowing up and all this, right? And I think, what does all this really do? I don't think it will create answers to, the basic questions that we have, but I think it will allow people to more quickly develop these answers to things and then make them more scalable, right? So say there is some solution to some policy problem, right? Like, say we tried to get some legislation passed that's going to stop, prior auth, right? But it didn't work, and it's still in the process, right? The long process of kind of legislation. Then what, right? And then you think, okay, well, I need to still do something for all these patients that I have, right? And so, you can take the action of saying, okay, I'm going to write a letter, each time something is denied, or write a prior authorization and look up guidelines and sort of, tailor it to the specific issue of this patient. Or you can use AI, and you can use some of the HIPAA GPT, tools and type it in. And I've tried this just to see what it does, right? But it will pull in all of these references, it will tailor it to your patient's specific things that are, obviously, generalized. And it makes everything that we're trying to do more scalable. And so I think that's just one example. But I think that the innovation then is going to be, okay, like, we're all thinking about the same problems and the same things that are affecting public health and patients and, burnout in medicine and this kind of thing. And so how can some tool or some innovation make it just a little bit easier, right? And I think it's achievable that it will happen, right? I think that, you guys talking about these things, just pointing out things that are a problem, and then there's always going to be someone who's like, okay, like, let's just do this. It's a tiny fix, but, these tiny fixes on the broad scale can really do a lot of good.
That's a very good roadmap for value-based care, as you mentioned. So where we introduce small, tiny tweaks to the outer circle, and then eventually make sure everything is scalable and affordable in the long run. And also, from your perspective, what I do understand that is AI as a whole, currently we can grab, like, the low-hanging fruits in the administration aspect, as you mentioned. But in terms of patient care, do you think it will establish health equity across the whole population because of the diversity of data that we need, the amount of data we need is a lot? What is your thought or perspective towards this?
Yeah, I think there's two parts of this innovation that can get into this health equity stuff, right? One of them is data, like you said, right? There's so much data out there, and there's so much, we've seen, companies and different industries, know that and they want access to data. And that's because on the broad scale of things, all this data can really show you trends, right? And they can show you, what is the future of, how certain infectious diseases are spreading, or what is the future of, if you look at these trends and all this data that we have in some way, you can say, okay, has this specific, regulation or this specific innovation, or has, for example, making PrEP available to people at no cost, right? Like, what degree has this helped, the spread of HIV, for example, right? The data there can really show you, are these innovations that we're putting in place, or are these regulations that we're fighting for working, and which ones are working better?
Adding to your point, and Mohit, if you remember, Dr. PK, he was our last guest. He is the head of clinical sciences at Inference. It's an AI healthcare company. He said that we went from anecdotal medicine, which was centuries ago, to evidence-based medicine decades ago, to now we're going towards data-driven medicine. And I think that's what you're talking about, which is like, we have all the data. Now we just need to sit down, look at the trends, and then kind of start making decisions based on those trends. That's where we are right now.
We need more Power BI tools right now.
You guys can come up with them maybe and kind of do it. It is this era of data-driven medicine. And the other part of it, you mentioned equity, right? And the flip side of kind of that, it can be if you have all this data saying, okay, here's where the money is and here's where big efforts are going to work. What happens to those areas on the fringes, right? And what happens to those areas where maybe you need to invest a lot more energy to see a difference, right? So I think that it's important to keep the focus on those, right? So I think it's important to keep equity in mind in terms of, okay, we're gonna focus on these things because we feel like we can get a big result in public health. But okay, what about these populations who, we maybe need to invest more time in to see a difference, right? So I think that it's important to keep that in mind in any kind of innovation that we're doing. But the other part of that is, a lot of innovations that we've seen do that, right? And they do help with equity. We saw certainly during the COVID pandemic, there was this big, explosion of virtual visits and streamlining how virtual visits work and doing all this remotely. It's helped people who don't have transportation or who don't have time or, don't have childcare and can't leave and go to the doctor's office and all this stuff. And so I think sometimes this necessity, breeds this innovation that can really help, on an equity level too, which is great.
It's kind of weird that you say that because it's like war is what caused so much of the technological innovation in the past, and so I think that's a pretty good corollary.
COVID was the biggest insight into innovations of technologies. Innovation towards the gaps that we have.
Yeah, I'm not saying we need more pandemics.
No.
It's interesting. Yeah.
All right. So I think for the final question of the day, looking ahead, what are some areas that you think that healthcare providers should focus on to create really scalable impacts and really get involved in advocacy? So target areas of focus where we can kind of get involved, where you see that, okay, this is where advocacy is needed at this point of time.
I think everyone will have a different answer to that question based on what they see every day and kind of what, that will shape what you think about a lot and what you think really affects patients. But for me, I'm really interested in the issue of healthcare pricing and healthcare price transparency, because I think that drives so much of access to healthcare, right? I think, at least in the US, if you look at our healthcare system, and one time I tried to write this memo that explained kind of the way that healthcare costs work in the US, and it turned into this 30-page thing, right? Because it's so complex and it's such maybe it's meant to be complex, right? So we can't solve it all, right? And I think it's a system where the price of something doesn't really have any match to the cost of it, right? And so there's all these layers of things, right? And so I think to the extent that can be simplified, or at least there can be mechanisms in place that will help, even if we're not going to just magically fix the whole system, right? I know there are a lot of barriers to that, right? We have a lot of infrastructure, we have insurance companies, but at least if we know some of those drivers and we're able to give some transparency to people and say, okay, if you can't get this medication, here are the things that can be done quickly to get it to you, right? Then I think that's helpful, because that's, at the end of the day, that gets rid of so much of the barrier to doctors, treating patients. But there are so many important things people know about that are problems and that they know how to fix and they have ideas how to fix. So I think that one thing that everyone can work on is ways to transfer knowledge to other people. Because I think that teaching, or if we have a streamlined way of, if I've developed something that can make me, easily advocate for a patient on this, or easily get a patient this, or easily do this in a system, that's great. But it's only really great if I can, scale that to everyone else, or if someone else can hook into a system and say, okay, what's been done and how can I do it? Because that's, I think, the way that you can just build on all these individual efforts that people are doing on the things that they care about.
So I think that when you improve the communication, or when you improve communication of knowledge from one person to another, you prevent the effort that goes into reinventing the wheel every single time.
So from what I gathered from what all you mentioned in terms of also healthcare pricing, you specifically mentioned about value equals quality over cost. So do we reduce the cost or do we increase the quality? Because technically the cost is a black box. No one knows why is it high. And since you have been experienced in multiple facets of life, what do you think is the healthcare system of the United States lacking in terms of quality? Because we do have a good quality of care from what I could gather. But what is your perspective?
Yeah, I think that's that could be a long conversation. I think you're right. I think that the real benefit of healthcare in the US is it's truly excellent, right? I mean, I see it every day, right? I mean, people, in terms of the quality of it, right? I mean, you can know that if you have this issue, you can find someone who is going to treat you and to offer you the best that is available, right? Whether that's gonna maybe lead you into some bankruptcy, that might happen, but you can find the care, right? And we have a lot of medications, a lot of resources. So I can't be down on the quality of healthcare, that we have, right? Honestly. But when you get into the problems and the equity problems, is just that, is the access to it and the ability to, down the line, once you've received it and people can receive it in a timely manner. But then what if you really can't afford, the follow-up care, or you can't, afford to continue taking the medications? And there are all these stories, right, of people who find this medication, it's not approved, it's maybe $1 million. I don't think it's a question of really increasing the quality. And I want to be able to keep driving innovation, right? So I don't want to say, let's take away money from pharmaceuticals, or let's take away money from people who are going to continue innovating and get patents. But like any system, there are a lot of loopholes, and there's a lot of just other stuff built in, right? There are a lot of middlemen. There are a lot of other things that are built in that maybe take some of the money but aren't really contributing to the ultimate creation of the good, right? And so I think to the extent that you can make these things more efficient and kind of take out those pieces that are not contributing a lot, great. And I think there are ways to do that. I can't list them in terms of right now. And I think that there are barriers to do it too. I'm not going to say that it's easy, because there are, whole industries and companies that exist now that employ people, that are built into the system. But I think there are ways to rethink the system and then have a plan to sort of, take out some of that excess and sort of make it a little bit more streamlined.
I feel like one of the ways that might work in the future is somebody comes up with a streamlined system of a mini version of this, and does a pilot somewhere in the US, does a study on it, does research on it, gives the data out, and then shows everybody that, hey, if you adopt this system, you're going to save a ton of money and a ton of time, and all of this is going to be better for all parties involved. It's going to be a win-win situation. And then that system gets adopted, I guess, by other industries and other people slowly and steadily. I don't think it's going to be a blanket ban or a blanket change. It's probably going to be very slow, but I think demonstrating that it's possible, I think that's the first step. Here's how we do it, and then we take it from there.
But there are many industries already built on this problem. I don't know whether they will be acceptable.
That's true. That is true. But
I think you're right. Yeah, I think that happens to a degree, right? I think the nice thing about states is that states can try things, and like you said, there's never going to be a huge 1 minute overhaul of everything. But there are also these smaller companies that build up that say, okay, let's try to just have our own system and see what happens. And there are problems there because you don't have a good accumulation of all types of people in society and everything. But I think you're right. I think you can see what happens, and then see if it works. And then again, I think that the crucial part is there, maybe you come up with something, but you need to have enough people in medicine who care about this, who are engaged, so that when whatever industry this isn't going to help is going to, kind of go against it, then you have enough people out there saying no, this is a good thing.
I think that was good. Mohit, if you have any other questions, I think
that's all from my end.
I think we can keep talking for 3 hours, I think, but I think in the interest of time, thank you so much for coming. Liz, you have been a pleasure to have. We've learned a lot today, and I hope our audience also kind of is inspired to get involved more in advocacy and start creating change at the grander scale of things, not just your own patient, but in the public health sphere. So thank you so much for coming.
Yeah, thank you so much, Liz, for coming.
Yeah, thank you guys. I really enjoyed it. It was a lot of fun. Thanks.
Yeah.